Sorry about that. Okay. So let me give you a brief introduction. Dr. Shyamsunder Kamath is currently a professor in anesthesia at SDM Dharwad. His specialty is cardiac and obstetric anesthesia with 35 years of experience in India, UK, and the Middle East. He completed his MD at Kasturba Medical College, Manipal, and also practiced there for more than 15 years. He has done his fellowship in the United Kingdom. Dr. Vidya Kamath is currently a professor and unit chief at SDM Hospital Dharwad since the last 9 years. She has done her MD in OB-GYN at KMC Manipal and has worked there for several years before working in the Middle East. So I will now hand it over to Shyamsunder Mam to get on with the talk. He will be talking about labor analgesia. So if any of you have any questions, please feel, after his talk, please feel free to ask. And one more thing I wanted to say was, if you have a question, you can even raise your hand, and then so that way I know who needs, who would like to ask the question, and then we'll let you do that too, okay? So, Mama, it's to you now.
Thanks, Ashima, for the nice introduction. Hanga Ashile, KAOCA office bearers, committee members, as well as the Prajanake, I'm Vidya Namaskaro. Today's session is mainly on women's health issues and their welfare. In this context, I thought I'll speak something about labor analgesia. Somebody must have like Kunashapuro, labor analgesia, Changani, Cherda White, Ausu White, Magiri, Amnipura, Malgada, and Ampura, very, very normal giant, and it was like labor analgesia, Roka, Tempera, unnecessary drugs, and Changani, and Theologian Santati, labor analgesia, Villari. Am I audible? Labor analgesia, Villari. Shastra delivery, forceps delivery, cherdasta, complication cherdasta, Mastana Sanguno, Ashilatin Maikuna Shapuro. How the Vaiki 90 more sound Sanspashpura. I will briefly tell you how this procedure is done. Yeah. Labor Murray. Balanted Duki. First stage on Tumare, uterine contractions start down. The first stage, the second stage, the baby expulsion stage. First stage on to pain, actually, dull pain starts at the frequency of uterine contractions. This pain is not sharp, it's very dull and becomes intense as the time goes. And second stage labor is very sharp and intense to the extent that kind of high comparatively. So they say it is the pain is akin to something similar to cutting your little finger without anesthesia. That's what they say. So first stage labor that Mari, the uterus nerve fibers pura. The thoracic level, T10 to T11, thoracic levels of the second stage, when the baby expulsion stage, the intense pain goes to a lower segment. So, first stage, they have touch area, your dull localized pain. Second stage, Tungu Bhagaka, sharp intense pain. Now, what are the various ways of labor analgesia? This is useful that in case your loved ones or your friends, you can advise according. That's why I'm explaining this. Methods एक neuraxis block में epidural एक combined epidural spinal monosta. Actually, don't think varieties are something. I will not go into the medical details. Second, systemic analgesia. Puri pura hospital delivery dalala pura epidemiology systemic analgesia pethidine like morphine is a narcotic. Pesalamari pain asleri door pain asleri uterine contraction some jainati. So to make the pain less and the uterine contractions proper, pethidine injection. This gives a good analgesia. The problem is pethidine, some part goes to the baby also. For some reason, if there is no appropriate timing of this pethidine, the peak levels get the baby which is harvest. In which case, sometimes the Apgar scores. Apgar score the baby well-being production scores. They would don't check. Whereas Duraxis Black has got absolutely no effect on the baby. Inhalational methods, for example, nitrous oxide, Entonox, during the delivery, the pain is the pain stop. The pain relief is not very good, maybe 30-40%, the maximum 50% pain relief. So there's not much of satisfaction of pain relief in this particular procedure. So there are non-pharmacological ways of labor analgesia. Psychoprophylaxis, touch and massage, heat and cold therapy, hydrotherapy like jacuzzi. So, hypnosis, acupuncture of acupressure, and trans-electrical nerve stimulation. It may give about 10 to 20% of relief. 80% pain will be there. So these are all not very useful, just a mild relief. They will not be 100% effective. So, before we administer epidural analgesia, which is the most commonest, 99% analgesia, epidural analgesia. First time, we have to establish the labor. What to do? Uterus gas we have to establish. Simply, we can't give epidural unless we establish the labor. That means to say that the gynecologist anesthetist contractions every 10 minutes, about 40 to 45 seconds. Pain and contractions. So we evaluate. The evaluation full history, past history, present history, documentation, contraindications. The contraindications, for example, there's an infection in the back. We cannot give the analgesia. Some coagulation disorders, we cannot give analgesia. And we take the written informed consent. Like any other medical, even if you take a dolo, there are some side effects. So if you take the tablet or this typical paper strip, adverse effects. There are very, very rare, 1 in 10,000 or 1 in 1,000 of the exam, mild headache, 1 in 1,000 patients. And that headache will be there for a couple of days. We tell everything. These days, we need to tell all these things so that legal issues will not be there in future. So how we start? See, when we give labor analgesia, we have to monitor mother's well-being, baby's well-being, as well as uterine contractions, because uterus health and uterine contractions are very important for a normal delivery. So there are 3 things: ECG and NIBP SpO2, that is electrocardiogram, non-invasive blood pressure monitoring, and saturation. This is for looking after the mother's well-being. Well, CTG, cardiotopograph, uterus contraction, plus at the same time, fetus heart rate, so that mother, uterus, fetus, all are monitored continuously throughout the labor analgesia. This is very important things we do. And start. It may look like a big procedure. It is not at all a big procedure. It is just to make it very sterile area. Rape, just like any other injection in the back, the needle, usual to make a vaccinating needle up a stick to hard stuff. So we do administer a bit of local anesthesia so that the needle was a pain out in the morning. There's full area paint for sonic injection. Then we administer a very tiny catheter, very 0.2 millimeter size the catheter with a galpati. Try curl. Honey, we start. The aim of this particular procedure is there should be only analgesia up to the belly button. Above that, you are feeling, and below your, like below on the thighs and all, you should not affect. There should be no motor blockade, but the movements, effect joint sensations effect so that you can move around. So choice of local anesthesia these are medical, some of the drugs which we use. The catheter, test dose, we give a infusion pump. This can be slow dose infusion for Thursday. And at the same time, some of the machines, they have patient controlled epidural analgesia. When the pain arises, the patient herself will press the button so that you inject some drug into the epidural space. So the analgesia will be there, controlled by the patient herself. So you can monitor and you can control the infusion pump. So advantages I'll now clarify. You get excellent quality of analgesia. Stress time for the mother, parents, in-laws, all the loved ones. So, anxiety, looking forward for the baby, at the same time, personal complications, at the same time, pain. The mother, there will be anxiety about the pain. So, whether this analgesia is worth it, because no pain. When anesthesia started in first anesthesia with 1842 Angachi in Connecticut, so what happened is people laughed at anesthesia. Before that, anesthesia surgery was done without anesthesia. 1942, everybody said, "What is this drug making unconscious?" To the extent that they made fun of the anesthetists. Anesthetists committed suicide for as well. Anesthesia properly started in 1846 in Boston. That is the first time anesthesia there. In fact, labor analgesia was first time given to Queen Victoria in 1853 when Prince Leopold was born by John Snowman. And chloroform was banned long back because there are a lot of adverse effects. So it is there for the last 200 years. Now, what happens if you give labor analgesia? Tension. That is because when there is a stress hormone and increased tension, the blood vessels constrict. When the blood vessels constrict, the blood supply comes down. So in the same way, when there is a stress and increased catecholamines like adrenaline and all that, and because of pain, uterus blood flow in wound. Uterus blood flow wound uterus such a contraction stability down. This is not my listening. This is by thousands of patient studies. It is published in US itself in 2007, 2006. I give the reference. So what happens is the delivery will be smoother and faster with analgesia, labor analgesia with epidural rather than giving any other or without anesthesia or analgesia. Right? So decrease plasma catecholamines and decrease stress hormones. Uteroplacental perfusion, uterus and placenta. Uterus blood flow is important for the healthy contraction of the uterus. Placental perfusion for the healthy baby. That is also better with labor analgesia. So it is better in both ways, and you don't require opiates like I said, pethidine and all those things. That goes to the baby also, and the ABGAS course will be better with the labor analgesia. I mean epidural analgesia. And mother is fully awake and participates in labor. And immediately after the baby, mother will be bonded fast. People think that the pain, in pain labor, the child is bonded. No, without pain, it's a pleasurable thing. Normal delivery plus complete pain relief, and the baby, newborn, new member in the family. It is one of the wonderful moments. So mother will be awake and participate in labor, and she'll be very happy. These are all by studies. And for some reason, which is the complication, very natural complications like the cord, umbilical cord, cesarean section, you need not give again spinal anesthesia. The same epidural can be made into anesthesia. Analgesia without only sensory blockade. Anesthesia full sensory and motor blockade. And general anesthesia both to So these are the given reference that is this published well in thousands of patients. They have found out ultimately it is so there is no labor analgesia cesarean section cured. No, not true. No adverse effects in the progress of first stage. Right? Faster delivery data. No increase in the instrumental delivery. Present day, labor analgesia has developed so much in the last 30 years. Now it's almost absolutely safe and extremely good for the mother. That's been established by studies. And it benefits even the previous section patients. Previous section patients are they will give a trial of labor. So she right? With this labor epidural analgesia, even the patient can dance around more. I mean to say that they can walk around with uterine contractions. The thirst, the labor progress, the thirst, at the same time, you're happily walking around. So this is the advantage of labor analgesia. And if epidural is for some reason contraindicated for some infection, Entonox, almost 50% pain relief, nitrous oxide and oxygen combination that can be taken, inhaled during the pain. But the analgesia is only about 50% compared to this. That's basically I have kept it very brief because my wife, there are a lot of questions from the audience, and so I will make my talk very brief and I'll hand over to Vidya. If you have any questions, what's the time now? How much time have you spent? 20 minutes. Okay. So you can ask later after the. You can finish now only if you have questions.
Yeah, I was going to say, if anybody has questions, please go ahead. Do I see?
Arun Uleta, sir. I have a question. My doni friends delivery jatari lower, hips below hips tani immobile jalan dog jada and I was just atatani early 50s and still they are immobile, and I was talking to them, and one of them mentioned to me that it is after delivery, so she was blaming it for epidural basically. Is it
long ago? When was
it? Was why she has a 23-year-old daughter and 25-year-old daughter, Varesa. So exactly. It was long time ago.
Correct. What has happened is, in the last 20 years, it has developed food that the drugs were not available. Present day, you get fantastic drugs, which doesn't cause this problem. I agree with you. This was happening. Last 20 years, the modern drugs and modern technology has completely eliminated this issue.
Okay. Thank you.
So I had a question as well. So there are no side effects at all to the epidural these days?
No, one in 1,000 or one in 2,000 people have a headache for a couple of days. That is because of the mild complication and especially the inexperienced anesthetists.
Okay. Because I know, like in the past, like Aruna mentioned, I didn't know about the immobility, but a lot of people experienced like back pain for years on end.
What I've given a reference in that you got all the details about this back pain issue. The back pain issue is not because of the epidural. It is something to do with the garbhakosha tonda, some problem. after delivery. They attributed it because it was Simon. There's a study reference, all these issues are clarified in that particular study.
Thank you. All right, anybody else with the questions? Okay, so I guess we will move on to...
Thank you, Bauji. It was a very informative. First time I heard, detailed Amchigal information about it. It was really helpful. Thank you so much.
I was not really.
I agree.
Okay, I'll hand over to Vidya. Okay.
Good evening. Namaskaru, Sakranka. I thank KAOCA for inviting me to give a talk on women's health. Okay, and let me start. So I am talking on 3 topics actually. I hope I can finish in, about 45 minutes. I'm talking about menstrual disorders, I'm talking about menopause and about cancer screening. So I may go a little fast so as to try to finish it. Okay, any questions you have, please, I think you can ask me at the end. And I've already noted down whatever questions have been asked over the...
I was going to say there are a lot of, we do have quite a few questions. So maybe
I've noted down the questions which were sent by mail to Naresh.
Right.
I have noted down the questions. Most of it would be covered when I talk, in the talk, and others I will just address it at the end of my talk. And anything, any other questions you can please ask me at the end.
Absolutely.
So I'll start with the menstrual disorder. Yeah. So from the time of the first period, that is called menarche, till menopause, and even after menopause, lady can face several problems in her life regarding her menstruation. So we, we classify it like this: problems around menarche, that is the first period, or in the adolescent. Problems in the adolescence, problems in the reproductive age group, that is 20 to 40, 45. Then problems around the perimenopausal age group, and problems in the postmenopausal age group. So that's how we classify it. So I'm going to tell in the go along the similar lines. Okay, the problems in adolescence are: a girl may attain menarche, that is the first period, around 11 or 12 years. In fact, now the age of menarche is advancing. It's becoming earlier these days because of better nutrition and other things. So girls are attaining menarche around by 11, probably 11. So the most common problem we encounter is irregular cycles. The mother is worried that the girl is having irregular cycles, so they bring them to us. But we must remember that irregular cycles are common for the first 2 years after menarche. 40% of girls will have this problem, irregular cycles, for the first 2 years. So we just have to reassure the mother. It's the mother who will be more worried about it. So we just have to reassure. But if the mother says, in addition to the cycles being irregular, if it is heavy, she has heavy bleeding, 10 days, 15 days, she bleeds heavily, then we cannot ignore that. We have to evaluate for the different causes, why it is happening. There are various causes for that. And then it has to be treated, because sometimes the bleeding may be very severe, their hemoglobin will drop. The hemoglobin, sometimes we have seen girls with hemoglobin coming with 6 grams, 7 grams. In such cases, we may have to admit them, give them blood transfusion. But if hemoglobin is 9, 10, then we just have to give them oral, that is tablets, iron tablets. And of course, we give medications to stop the bleeding. But of course, we do have to do certain blood tests and some maybe an ultrasound, some basic investigations to find out why she is having heavy bleeding. So if the cycles are irregular, less heavy bleeding, it has to be investigated. But otherwise, irregular cycles, we just have to reassure them. Then one more thing is, even after 2 years, if the periods are irregular, then definitely they have to see the doctor and we have to find out what exactly could be the reason. I would like to tell one important thing here is, the child may go into a college, hostel, a change in environment, like getting into a hostel, all these are cause stress to the child, and there can be a irregular cycles, a change in environment or a fever or any kind of stress. So the periods may be irregular. So we just have to reassure them. The best is, any lady for that matter with the irregular cycles, we ask them to maintain a menstrual calendar. That's the best way, because everybody's memory is, is not quite good. We don't remember when was the last period. So best is to have a diary where the dates are written. So it will be easy for the doctor to find out what exactly was the irregularity. So if they write down the dates, or these days we have the mobile, they can just enter it in their mobile as to the when they have got the periods. So that is one thing about irregular periods. Number two, another problem is, if they have not attained periods even by the age of 15 years, if a girl has not attained periods, not started menstruating by the age of 15, then it needs to be investigated. There are so many causes for that, which I am not going to talk, because it's a chapter on its own. So there are so many causes, but the child has to be brought to the doctor and investigated. In fact, the mother themselves, they'll be very anxious. They will only bring the child to say that she has not yet attained periods. Then one more problem is pain during periods, which we call as dysmenorrhea. Pain during periods is a normal, it's a physiological phenomenon. It is normal. We just have to reassure them. Of course, we have to take a history, examine them also. Examine means it's only, we don't do an internal examination. And we just have to reassure them, give them analgesics. And most of the time, this pain, dysmenorrhea is relieved by analgesics. But at times, we find this pain may be very severe. The pain may come before periods, during periods, and if pain is there even after periods. It becomes worse with each cycle. Sometimes they dread getting their periods because they know during periods they have severe pain. If such a kind of pain is there, then, or if there is a family history, the mother had endometriosis or a sister is having endometriosis, a condition called endometriosis, which can run in family, then the girl needs to be evaluated. Then what we do is, we examine, when we ask for an ultrasound, we rule out endometriosis, because if it is endometriosis, it definitely needs to be treated. Otherwise, most of the time, pain during periods are normal, mainly reassurance and analgesics. And usually by the time they become 20, 21, it will be relieved, or after childbirth, it will be, they will not have any dysmenorrhea. Then coming to the problems in the reproductive age group. Now this is 20 to 40 or 45. This is the most important problem which we face is absence of periods. They tell that they have missed their periods, no periods. The first thing as obstetrician, we think of pregnancy. Whether a girl is married or not married, it doesn't matter to us. We are always highly, our mind is always tuned to pregnancy. And these days, of course, whether it is even in India, we have to be aware about this. So we always keep in mind about the possibility of pregnancy. So that's the first thing which we rule out. If she has missed her periods and she has severe pain, giddiness, we have to think of ectopic pregnancy. That is pregnancy occurring in the fallopian tube or ovary or something. It causes severe pain and it's a very dangerous condition. That is why we should not miss this condition. That's why I said the obstetricians are tuned to it. Anybody who has missed the period or anybody has missed period and severe pain, we always think of ectopic pregnancy. It is said that we can overdiagnose ectopic, but we should not miss an ectopic because it can be life-threatening. So ectopic pregnancy is one thing which we have to rule out. Number two, pain and bleeding. It could be an abortion, a miscarriage. It could be in the process of miscarriage. That is, when she has missed her periods, pain and bleeding, we have to think of a pregnancy-related condition. Then there are other causes why they may not get periods. One is a thyroid disorder. Thyroid disorders can cause amenorrhea, that is absence of periods. It can cause heavy menstruation. So thyroid is, it's a quiet organ, but it is very much important for the normal menstrual cycle. So a menstrual cycle disorder could be either due to hypothyroidism or hyperthyroidism. But among the two, we find hypothyroidism is more common among women. Then certain medications can also cause lack of periods, like somebody may be on antidepressants. Some medications can suppress, the action is on the hypothalamus-pituitary axis. So they may not get periods. Certain drugs will cause this. Then PCOS. Okay, I'll be talking a little later about this. Polycystic ovarian syndrome can have irregular cycles. They'll have periods of amenorrhea. That is, they may miss their periods. Then too much of an exercise. These days, everybody is health conscious. So too much of an exercise also is not good. Exercise-induced amenorrhea. We call it as exercise-induced amenorrhea. Anxiety, stress, I already mentioned, some mishap in the family, some death of a close relative. Okay, all this can suppress the menstruation. Obesity. One more thing, when a person is breastfeeding, the person may have absence of periods, or he can have even irregular periods. Contraceptives, like we have the injectable contraceptives like DMPA that is given once in 3 months. This injection is given. Of course, before giving these injections, the doctor usually tells the woman that these injections, the periods will be irregular, or she can have amenorrhea. This has to be explained. In fact, this is very, very important that we tell the patient that she will not get a period, or her periods will be irregular when we give this injectable contraceptive. Then comes LNG IUCD. That's also a contraceptive. It is used for other purposes like heavy menstrual bleeding. That also will ultimately cause amenorrhea, that is absence of periods. Then, of course, chronic illness like tuberculosis. In India, tuberculosis is common. It can occur even in the higher socioeconomic status. We must remember that. Then there may not be any other symptoms, but we may find genital tuberculosis. So they'll come with absence of periods, tuberculosis, then chronic liver disease, renal disorders. All these can cause absence of periods. And of course, pituitary tumors. There will be high levels of prolactin. When prolactin levels are high, the periods will be suppressed. So there are various causes, but as I told, the first and foremost thing is we think of pregnancy-related conditions when a patient comes with absence of periods. Then other problem what we face is heavy periods. Many times, this is the most common, I should say, women who come to us, they complain of heavy excessive bleeding during periods. That is, they find that the periods are heavier. So then it is very important that we rule out certain things. And the most common are fibroids. It is not cancerous. We must remember that. It is a benign condition. It is a non-cancerous tumor of the uterus. It's a very, very common cause of heavy periods. In fact, the patients are worried when we say there are fibroids. I mean, it's a tumor. When they say tumor means they think it's a cancer. So it is our duty to explain to them it is 99.9% they are not cancerous. Fibroids are not cancerous, 99.9%. So, that aspect we should reassure them. Okay, then of course the treatment varies depending on the size, depending on their age group, whether they want to have children, and so many factors. So one of the cause for heavy periods is a fibroid. In fact, I should say many of the cases of fibroids, they are asymptomatic. About 30% of women around the age of 30 years, 30% of women will have fibroids. So just because they have fibroids, it doesn't mean they have to be operated. They may be asymptomatic. They may not have any symptoms. In fact, it may be an incidental finding. For example, many times They will have some upper abdominal pain and they go to the surgeon. The surgeon will say, get an ultrasound done, and the ultrasound will show some gallstones. And the radiologist naturally will see the whole of the abdomen, and then he will see the uterus and he will tell there are multiple small fibroids, 2 into 2 centimeters, 1 into 2 centimeters. So the patient will be worried, and then they will come rushing to us saying, the minute they come to us, they will just trust the reports to us. They'll tell, I've been diagnosed as fibroid, what should I do? They are not, first we ask them, what are your symptoms? They are not worried. They'll tell, no, I've been told that fibroid, do I need surgery? That is the thing. So if it is, I told you 30% of women around age of 30 will have fibroids, but it doesn't mean that all of them have to be operated. Only if it is giving rise to problems, it has to be operated. So it may be an incidental finding. Number 2, one of the other cause for heavy period is a condition called endometriosis, which I already mentioned that time. So it is actually endometriosis is the inner lining of the uterus is present normally within the uterine cavity, but sometimes abnormally it is present outside the uterine cavity and give rise to so many problems. Severe pain during periods, then it can cause infertility. That's another important cause. Infertility, severe pain during periods, then irregularity in the menstrual cycle, then they'll have pain during intercourse, pain during passing urine, so many problems. So endometriosis is another difficult condition. They can present with heavy periods. So also adenomyosis is nothing but same. The uterine lining goes, it is present within the myometrium, within the uterus, the muscles of the uterus. Then there is something called PID, that is infection of the genital tract. A presence of an IUCD, which is used for contraception, that IUCD itself can cause heavy periods. If it is displaced, it can cause heavy periods. Certain medications, OAC, that is oral anticoagulants. A patient may be having heart disease, some valve replacement has been done, and she is on anticoagulants like warfarin. That can, the side effect of the warfarin, so she can come with heavy periods. So when a patient comes with heavy periods, we take a proper history, we have to examine and evaluate them. And then of course the treatment will depend. So pain during periods, again, these are some of the causes, again, fibroid, PID, endometriosis. So these conditions will cause heavy periods as well as pain during periods. Now coming to the perimenopausal age group. Now this is a very, very important age group. Many a time they come with irregular cycles, heavy bleeding, and they attribute it to menopause. They'll tell, okay, I'm approaching menopause, so it must be like that. So, but it's very, very important that any person above the age of 40 or 45 with irregular bleeding should undergo a detailed examination, a pap smear evaluation, an ultrasonography of the uterus, and if needed, endometrial evaluation is nothing but a biopsy, endometrial biopsy or a DNC, before we start any treatment. So anybody above the age of 40 with irregular cycles needs to be evaluated thoroughly. As I already mentioned, it is better to maintain a menstrual calendar when a person is having irregular cycles before you go to the doctor. Then comes the postmenopausal. A postmenopausal bleeding is not normal. Not normal at all. It is definitely abnormal. It has to be seen by the doctor. The most important things which we have to rule out are cancers. Cancer of the uterus, cancer of the cervix. These are the two important things. All the other things are all, what shall I say, minor things which we are not worried about. So whenever a patient comes to the OPD saying that she has attained menopause and now she's having bleeding, immediately our mind will start worrying, oh, I hope it's not cancer, So when it is not cancer, we'll be very relieved, because all the other things can be easily managed. Okay. Then coming to the another important topic of PCOS or PCOD. I think one of the questions was on this. It is common in adolescents, but it can occur in all the age group in the women. And it is one of the causes for irregular cycles or infrequent cycles. They'll come saying periods are once in 45 days, once in 60 days, or once in 3 months. Very often they are obese. There is increased hair growth that we call it as hirsutism on the upper lip, on the chin. Sometimes the excessive hair growth may be seen even on the chest, on the abdomen, and there can be even acne. Okay, these are all because of hyperandrogenism. That is, the more of the male hormones are more in them. It's a hormonal disturbance actually. And not only that, this PCOS, basically there will be high levels of estrogen in them. The egg doesn't come out in these people. So later on they can present with infertility, that is inability to conceive. Another most important thing is PCOS is associated with insulin resistance. So they'll come with, we have to look into it. We have to check for the, we have to do a GTT or the blood sugar testing. Basically, in other words, they will develop diabetes. And if left alone, these women, because of excessive estrogen in them, they can develop endometrial cancer later on in their life. So we have to keep this in mind, and we have to take steps to prevent that. In other words, they need medicines like progesterone to counteract the effect of the excessive estrogen to reduce the incidence of endometrial cancer. So the treatment of PCOS again depends upon the age, at what we see, desire, whether they want to have children. And the most important thing, what I advise them, when a PCOS patient, when we diagnose PCOS, I tell them prescription, number 1, and I tell weight reduction. Number 2, weight reduction. Number 3, weight reduction. This is the most important thing. Even if they reduce 5% of their weight, it is sufficient. By that time, the cycles will start becoming regular and the ovulation will start. So a 5% reduction in their weight is sufficient. So this is what we have to stress upon, that weight reduction, weight reduction, weight reduction. Then of course we have medicines like the oral contraceptive pills. Some parents may be worried, why is the doctor prescribing oral contraceptive pills? It is mainly to reduce the LH, to reduce the, to bring back the hormonal, to correct the hormonal imbalance. Either we give them oral contraceptive pills, or we can give them, in the second half of the cycle, we can give them progesterone to overcome the excess estrogen. Then of course, if they are married and if they want to have a child, actually it's easier to treat PCOS when they come to us asking to have a baby. We have to just induce ovulation and make them pregnant. Okay, this is an easier way. Then of course, as I told, they need to be, we have to remember that they have a higher chance of endometrial cancer, and we have to tell them that, and we have to do an endometrial surveillance. In other words, on very frequently we have to do the ultrasonography, endometrial biopsy to see whether there is the effect of this hyperestrogen in them. And of course, then there are other medications like metformin, mainly for diabetes, myoinositol, which will help in the management of that hormonal disturbance. But we have to remember one thing. This PCOS is a very, very difficult thing. We can talk for hours. In fact, yesterday I got a mail. There is today a conference in India. The whole day the talk is only on PCOS. So it is such a vast subject, PCOS, and the last word about PCOS has still not been told, because things are evolving, things are keeping on changing. So the last word has still not been told about PCOS. And one more thing I want to tell you is, in the younger age group, it's actually difficult to diagnose PCOS, because in a young girl, the ovaries are active. So the ovaries may look cystic. And the radiologist or the sonologist will not know the details of this. They will write it as polycystic ovaries. And then the mother will see the report and will start getting anxious. Oh my God, my daughter is having PCOS. So in fact, it is said that ultrasound is not necessary for the diagnosis of PCOS in adolescents, because we may overdiagnose PCOS depending on ultrasound. That is one thing what is being told lately, that we should not depend on ultrasound for the diagnosis of PCOS. We will be overdiagnosing PCOS. Okay. Then coming to the other topic about menopause. Menopause is, everybody knows it's a permanent stoppage of menstruation. So what happens is basically the ovary stops functioning, or the function starts coming down. So there is a reduction in the ovarian hormone, that is mainly estrogen and progesterone. The estrogen is the one which is very much needed. So what happens is at menopause, the ovary goes to sleep. Ovary goes to sleep, and then there is no more estrogen. And all the problems of menopause are because of lack of estrogen. Now we can say a lady has attained menopause 12 months after she has had her last period. In other words, let me say she had her period today, and then for 1 year she has no periods, then only we can say that she has attained menopause. It's a normal, natural event. Average age is 51 years. And we say a person has attained premature menopause if it occurs before 40 years. Sometimes it may happen if you do a surgery for some reason, we have removed the uterus as well as the ovaries, then it is called surgical menopause. Or she might have had undergone chemotherapy or radiotherapy, where the function of the ovary is knocked off. Then it is called, that is a premature menopause due to the chemotherapy or radiotherapy. So it's menopause is a period of change. There are a lot of hormonal changes, physical changes, emotional changes. And it's the end of menstruation and childbearing years. So I told you the ovary stops functioning. So there are no more eggs coming out. The lady cannot become pregnant. I mean, biologically, she can't become a mother. She can become a surrogate mother. These days, we know that women can rent a womb. Okay, so, but she cannot become a biological mother. In other words, her ovary is not producing eggs. She cannot become a mother. And these are the two important things. End of childbearing, end of menstruation, and the hormonal levels come down. So when does it occur? It typically occurs between 42 to about 54 years. 52, 42 to 52. Is defined as the day when a woman has not had a period for 1 year. Okay. Now this is the graph. See, what I'm trying to tell you here is, now the life expectancy has gone up. In general, human beings are living for have a longer life. People are living up to 80, 90, 95. So you can imagine here, see, the life expectancy has gone up to more than 80 here. This is in 2000. It has gone above 80, almost 85. So which means if a lady attains menopause at 50 and she lives up to 80, she is spending more than 1/3 of her life after menopause. So that is the importance. So we know that estrogen and progesterone, that's ovarian hormones, is necessary for, it affects all the organs in the body. Okay. Now these menopausal women, I mean, about 20% do not have any problems. 20% can have severe symptoms, and it may be mild to moderate in about 60%. No two women experience menopause in the same way. It is different for each person. I will be talking only about the important things in menopause. One is the vasomotor symptoms. This is known as the hot flush or hot flashes. Okay, this is that 2/3 of perimenopausal women can have these hot flushes. 2/3. So you can see how 2/3 is quite a big number. 66 out of 100 or 6 out of 10 women can have vasomotor symptoms, but it is severe in 10 to 15%. So 1 out of 10 women will have severe symptoms. So it is nothing but a sensation. They feel very hot or warm in the upper part of the body and the face. The chest, neck, and the face, they feel very warm. It's a very transient, it lasts for 2 to 5 minutes. Actually, 2 to 5 minutes is a long time. If we calculate the seconds, 5 minutes is a long time. 300 seconds. It can keep recurring. This hot flushes, the feeling of sensation of heat, and it is associated with sweating and palpitations is nothing but the person will be able to feel the heartbeat, fast heartbeat, sweating, palpitations. It can occur in the night or in the day, but it is more severe in the night. So when it happens in the night, the woman gets up from her sleep So her sleep is disturbed. Then what happens when it keeps on recurring, she becomes more and more anxious. That itself becomes a vicious cycle. It will affect her sleep. So, and this hot flashes can last up to 1 to 2 years. And in some women, it can last up to 10 years. So it can be really severe in about 10 to 15% of the women. So why I'm talking about this is vasomotor symptoms are one of the indication for hormone therapy. This is the indication for hormone therapy in the present scenario. So it can start as early as the late 30s. It can peak in the early 50s and can last up to mid 70s. The first 5 years tend to be the worst. So, she'll have feel very hot, so she needs a fan. So how to manage this? Avoid triggers like hot drinks, caffeine, alcohol, breathing techniques, sealing, have a bedside fan, cool evening shower or bath, dress in light clothing. Okay, these are all the suggested things, lifestyle changes. So avoid the triggers, that is important. Then apart from the hot flushes, the next important thing is the vulvovaginal atrophy. That is because of lack of estrogen, the vaginal epithelium becomes thinned out. So also, so they can have, itching on the vulva, vagina. Then because of thinning of the epithelium, they can have pain during intercourse. Recurrent urinary tract infection. And this is seen in about 10 to 40% of postmenopausal women. So now in the present scenario, I told you the hormone therapy is mainly for vasomotor symptoms and for this particular problem, vulvovaginal atrophy. For this problem, actually, we can advise them local vaginal cream of estrogen. Estrogen vaginal creams are advisable. So sleep disturbances are common with aging. And as I told you, hot flushes can make it worse. She'll wake up from her sleep. It is said that keeping one's person first being active, exercise can help these patients. So midlife women should be counseled that declining memory and concentration problems are probably not related to menopause, but rather due to normal aging. So reading for approximately half an hour every day is likely to enhance the memory. Mood troubles. Many women report moodiness during the menopausal transition. Depression is more common among newly diagnosed menopausal women. Depression, moodiness, feeling of upset, irritability, fatigue, all these also are caused because of the fluctuating hormonal levels. So we must remember that menopause is a little difficult time. That is the age around 50. You can understand she may have other medical problems. The spouse may have other problems. There are elders to look after at home. There are children, problems of children in studies, or children going away from home. It's also known as the empty nest syndrome. I'm sure some of you would have heard it. Empty nest syndrome. The children go far away. Children are not there. Their own sickness, looking after elders, all that will also affect their mood and mental well-being. These are menopausal woman is the moods of the menopausal woman is described to the 7 dwarfs. It's supposed to be itchy, bitchy, sweaty, sleepy, bloated, forgetful, and a psycho. This is, jokingly, they have compared a menopausal woman to the 7 dwarfs. Now, osteoporosis is another important thing. When the estrogen levels come down, the bones become weak. So there is a reduction in the bone strength. And this is a serious health threat because of osteoporosis, they are at a higher risk for fracture. It is said that 2/3 of the bone loss occur during the 5 to 7 years around the menopause. It is because of reduced estrogen levels. So there is bone loss, higher risk of fractures. About 50% of women older than the age of 50 will have an osteoporosis related fracture at some time during their lifetime. It is a very scary thing. 50% of women above the age of 40 is every alternate woman above the age of 50 can develop a fracture. It's really scary. It's a silent disease, okay? Fracture may be the first sign of osteoporosis. Fractures of the spine and hip can severely restrict the quality of life. And 1 in 4 hip fractures can result in death within 1 year. So if there are 4 women having a hip fracture, 1 of them may die within a year. So they'll be bedridden when it is a hip fracture. So it's a silent disease. So this is the picture how a normal bone looks, and this is how an osteoporotic bone looks. It's all cavities. You can see all the calcium is lost from the bone. So the universal recommendations for the prevention of osteoporosis is lifestyle management, like a balanced diet, adequate physical activity, very, very important. Don't be a couch potato. Exposure to sunlight. Okay, again, this is becoming rare these days. Everybody within the house, work from home, not exposed to sunlight. Avoid smoking, tobacco, alcohol, and of course, adequate nutrition. This is the recommended this thing. Calcium, which is essential for good bone. An average diet may contain only about 500 milligram per day, but the recommended intake will be for a menopausal woman around 1000 to 1500 milligram per day, and should be taken in divided doses. And remember, calcium therapy alone is not enough to prevent fractures. It's not only milk. I'm sure everybody knows what are all the foodstuffs rich in calcium. They have the dairy products, milk. Yogurt or curd is a very rich source of calcium when compared to milk. I think 1 cup of yogurt will give about 250 milligram of calcium. Then cheese, then ragi is a rich source of calcium. Almonds are a rich source of calcium. Fish is a rich source of calcium. Then of course, soya bean, green leafy vegetables. Then certain fruits like strawberry, raspberries, kiwi, orange. There are so many. Chia seeds. Chia seeds are a rich source of calcium. Vitamin D. Again, vitamin D is important to maintain bone health. Most recommended to at least 1000 international units per day. And deficiency is due to limited sun exposure, not going out in the sun. Use of sunscreen, again, it prevents vitamin D production. And food sources do not contain adequate vitamin D. In fact, vitamin D is more important than calcium. So now, vitamin D is present in all these fortified milk, like soya milk, almond milk, oat milk, breakfast cereals, and fish, of course. Salmon, tuna, mackerel, I don't know what these different fish are. Fish liver oil, and another important. Cheese, egg yolk, all these are sources of vitamin D. So prevention of osteoporosis is mainly by a healthy diet, adequate calcium and vitamin D, and most important is regular exercise. So for about the cardiovascular health, I'm sure most of you are aware, the cholesterol level should be less than 200 milligram per DL. HDL should be more than 50 milligram. And LD, low density lipoprotein should be less than 100 milligram. Blood pressure should be normal. Blood sugar should be less than 100 milligram. BMI of less than 25. No smoking, a healthy diet, and a good physical activity of 150 minutes per week of moderate exercise. I mean, at least 20 minutes of exercise, rigorous walk per day for at least 5 days in a week is supposed to be sufficient. So to prevent heart disease, okay, again, lifestyle modification, obesity to be prevented, okay, try not to become obese, be fit, maintain the blood pressure, avoid smoking, avoid stress, easy to say that, avoid stress. Then plenty of fruits and vegetables, avoid alcohol, and maintain the blood lipids. So what are the management options for menopausal symptoms? I already told about the nutritional recommendation, balanced diet, reduced fat intake, maintenance of weight, calcium, vitamin D, limit alcohol, smoking, and caffeine. This is a diet which will provide all the vitamins and minerals. This is how it is. Plenty of fruits, vegetables, cereals. Then comes the hormone therapy. Hormone therapy for menopausal symptoms, I already told you. Since the ovary stops functioning, there is no more estrogen and progesterone. So basically, when we say hormone therapy, we are giving them artificially, we are giving them estrogen and progesterone. And as already mentioned, the most important indication is for the hot flushes and vaginal dryness. It is also effective for the prevention of osteoporosis. Now, I want to tell you one important thing. When the hormone therapy was started in 1960, many years ago, people were very excited. Women thought, okay, now it's a magic pill, wonder pill, where I can remain young forever. So they were very excited and people started taking hormone therapy. And then came the disaster, It was found that, this hormone therapy taken indiscriminately without proper evaluation can increase the risk of breast cancer, can cause clots, thrombosis. So all that euphoria of having got the magic pill disappeared. In fact, there were a lot of trials done on this hormone therapy. Lot of trials, the Women's Health Initiative, Million Women's trial, so many, the nurses trial, several thousand women were recruited. In fact, some of the trials were stopped halfway because they found the complications were so high, the trials had to be stopped halfway. So the euphoria of having found these the hormones for hormone replacement therapy died down. But that was because these women were not selected properly for the trial. All the women were given the medicines, irrespective of whether, without looking out for contraindications. In other words, they should have been evaluated properly and given. Then probably we could have found out who are the women who are suitable. So what I'm trying to tell is, hormone therapy has its own risks. So the women have to be chosen carefully. So now hormone therapy are available in various forms. We have these transdermal patches, the tablets, we have the vaginal creams, vaginal tablets, and so on and so on. So the aim of hormonal therapy is mainly to improve the quality of life to relieve menopausal symptoms. That's what I said, mainly vasomotor symptoms and for her vaginal symptoms. And the decision to start the treatment and the selection of treatment modality should be individualized. You cannot make a blanket statement. For everybody, I'll be prescribing this. Everybody, I'll give this dose. No. We have to individualize the treatment for each patient, depending on the risk factors. So I told you this is the repetition, okay, mainly for moderate and severe vasomotor symptoms or the genitourinary symptoms. And the most important thing in hormone therapy is the smallest dose for the shortest duration. This is the dictum for us. Mantra, smallest dose, shortest duration. And definitely not more than 5 years. Because I told you the two important problems with the hormone therapy are clot formation and breast cancer. So before hormone therapy is started, a detailed workup should be done. You have to take a detailed history, whether there's a family history of breast cancer, whether the person herself had breast cancer before. You have to take whether she's a diabetic, hypertensive. I mean, so many things we have to ask. We have to do a detailed examination of the blood pressure, the breast examination, a gynecological examination, pap smear, an ultrasound, mammography, some blood tests, lipid levels. All those have to be done before we initiate the hormone therapy. Not only before initiation, even at regular intervals during the hormone therapy, the patient has to be evaluated regularly. And of course, we have to counsel the patient properly. We have to really decide whether she really needs or not. We have to weigh the benefits versus the risk. You have to see what are all the benefits, what are all the risks. And the patient should understand what would be the risk, what are the benefits. And after a thorough evaluation, thorough counseling, after a consent, then only the hormone therapy is started. So what are the alternatives we have? We have other medications like phytoestrogens, like the soya. Okay, again, the soya beans, we can have use soya flour, they use soya flour along with the wheat atta when they make chapatis, you can use the soya flour. Then something called tofu. Okay, they are phytoestrogens, nothing but plant estrogen. Okay, so this can be used as an alternative to hormone therapy. Then there are other things like black cohosh, cranberry. Okay, cranberry juice we can always use it for urinary tract infection. And these are all plant-based. St. John's wort, red clover, green tea. Many of you would have heard a lot about green tea. All these. But the data is still insufficient regarding their efficacy. I think there was some question regarding some, okay, I'll come to it at the end of the session. Then of course, lifestyle changes, try relaxation techniques like yoga, meditation. I already mentioned about a healthy diet, fruits, vegetables, plenty of water, calcium and vitamin D supplements, regular physical activity. Avoid caffeine, alcohol. Okay, these are the triggers for hot flushes. Dress in light clothing, sleep in a cool room, consume cold drinks. Okay, these are all certain lifestyle changes. This is exercises, yoga. Then regarding a little bit about the health screening at the age of 40, again, what we can do is all women, we need to take a proper history, a personal history, family history, a detailed examination, including the height, weight, the blood pressure, then of course the breast examination, then routine blood tests like CBC, so the hemoglobin, urine test, blood sugars, LFT, RFT, then the breast examination, self-breast examination. Okay, all women should be encouraged to do the self-breast examination. Okay, if you go on the net, you will, the details will be given. She has to do once a month at least, because she'll be able to detect any small tumor. She can be able to detect it at the earliest, so that further investigations and management can be started at the earliest. But of course, studies say that self-breast examination is really doesn't reduce the mortality due to breast cancer. Then comes mammography. Okay, I'll be talking about the guidelines, how often to do that. Mammography. Then of course, a pelvic examination, a pap test. Again, I'll tell that later. Then an ultrasound of see the uterus, the thickening of the uterus. Then this is the picture of the ovary. Okay, we can have a evaluation. Then of course, cardiovascular risk assessment, that is the treadmill, and then the coronary angiography. Okay, of course, we don't do this regularly. We just refer them to the cardiologist, and the cardiologist will decide whether all the angiography and all has to be done. So menopause is a time of transition. It's not a disease. The options for symptom management include lifestyle changes and, if needed, appropriate medications. Regular exercise is the one which is most important. So begin today itself. Following a healthy eating plan, maintain a healthy weight. It is possible to live well with menopause by adopting a healthy lifestyle. And this is the general principles and holistic approach. The same thing what I told, it's a repetition, lifestyle changes, exercise, brisk walking for at least 40 minutes, at least 5 times a week. That should be sufficient. Physical workout, yoga, meditation, diet, rich in vegetables and fruits, avoid fats, avoid sugar. Anything white is supposed to be bad. Sugar is bad. rice, white rice is bad, maida is bad, white, anything white is to be avoided. That's why we have gone in for whole wheat bread, brown rice, they are supposed to be better. Plenty of fluids to maintain hydration, avoid alcohol, smoking, coffee, reduce coffee and tea. Then coming to the cancer screening, menopause itself is not associated with any increased risk of cancer, but it is, as we all know, that the incidence of cancer, any cancer for that matter, increases with as age advances, a person is at a higher risk for cancers. Okay. There are some cancers which can occur even in the young age. Okay. So screening is very important. So breast cancer screening, they suggested that mammogram to be done every 2 years between the age of 50 and 70. This is the guideline by the United States Preventive Services Task Force. Now, I'll tell you these things about these. There are so many guidelines which are in fact very confusing. The American Cancer Society says you have to start at 40, whereas this USPSTF says you have to start at 50. So though they themselves are not at a consensus. And the guidelines are put by the American College and they are put by the Royal College in England. So none of them are in consensus. A little bit of variation will be there and there. So I told you the American Cancer Society and the CDC recommends cancer screening at the age of 40 itself. But this US Preventive Service Task Force says between the age of 50 and 74 every 2 years. But we have to remember that high-risk women in the sense, women who have a family history of cancer, breast cancer, like for example, mother might have had breast cancer, sister must have had a breast cancer, then these women are at a higher risk and these women should, we should start screening them early. So also women with, if there is this genetic cancers like this BRCA1 mutation, BRCA2 mutation, you might have heard about it, read about it. In such women where there is a higher risk of breast cancer, screening should start by the age of 30 years. You might have heard of Angelina Jolie. Angelina Jolie has undergone, she came into the news because she underwent bilateral mastectomy, removal of both the breasts, removal of her ovaries also, because her mother had breast cancer and then they found that she had that BRCA1 mutation. So in these women, cancers occur much early, at a younger age. So they are at a higher risk for breast cancer as well as ovarian cancer. So Angelina Jolie underwent bilateral mastectomy as well as oophorectomy as a prophylaxis. She didn't want to take any risk, so she underwent mastectomy and oophorectomy. Of course, not everybody has to undergo mastectomy. There are medications like tamoxifen to prevent breast cancer, but she opted for a mastectomy. So high-risk women, screening should be started early. And of course, I told you self-breast examination every month should be encouraged for all women. Now, regarding endometrial cancer and ovarian cancer, till date, there are no satisfactory screening tests available for endometrial and ovarian cancer. You have to remember that. Only thing, when they come with postmenopausal bleeding, then we subject them to an ultrasound and an endometrial biopsy. So there is no satisfactory screening test. So far there are no recommendations by any of these organizations. As I already mentioned, when there is genetic mutation like BRCA1 or BRCA2 mutation, there are higher chance of breast cancer. You have to remember, among all the breast cancer, only 5% of breast cancers are due to these mutations. You have to remember that. Not all breast cancers are due to this mutation, but in the presence of this mutation, the chance of breast cancer is about 60 to 80%. So these women should be started to be screened earlier. Then there is another entity called the HNPCC, that is, it's also known as the Lynch 2 syndrome. HNPCC is nothing but hereditary non-polyposis colorectal cancer, also known as the Lynch 2 syndrome, where these women are at a higher chance of endometrial and ovarian cancer. So these women should be screened earlier. By the age of 35 years, we start doing ultrasonography to them, the ultrasonography of the uterus, and we do the endometrial sampling. In fact, they are advised hysterectomy with removal of ovaries at the age of 35 itself. We tell them to complete the family before 35 and then better to remove the uterus and the ovaries, because they are at a higher risk for endometrial as well as ovarian cancer. Chance of endometrial cancer is 40 to 60% and ovarian cancer is about 10%. Now, I just want to tell you, I mean, I know of one family who, I mean, all these genetic mutations are rare. I know of one family who had, one of the male person had the colon cancer, the sister had endometrial cancer, another sister's son had colon cancer, so probably it was Lynch 2 syndrome. So such anybody in the family should be screened for endometrial and ovarian cancer, and they may be advised hysterectomy and removal of ovaries. Then coming to cancer cervix, cervical cancer screening. Between the age of 21 to 65 years, every woman should have a pap smear every 3 years. Every 3 years. If we are combining HPV DNA testing, then it can be done every 5 years. So the recommendations are 21 to 65 years every 3 years. But after 30, only the HPV DNA testing is done. If HPV testing is done, HPV DNA plus PAP every 5 years. If it is only PAP, then every 3 years. But before that, we should have every year PAP has been done. If it is normal, then we go on for every 3 years. I hope it's clear. So every year a PAP is done. If all the 3 reports are normal, then we continue to do every 3 years until the age of 65 years. So after 65 years, then PAP smear screening is not indicated. So that's all about the menstrual disorders. I have touched upon menopause and about cancer screening. And now coming to those few questions which were sent to me yesterday. Okay. The question was...
Do you want me to read out the questions to you?
No, I have it here. I have it here.
And I think we have a few more in the chat, so I can...
I'll finish. I'll answer the yesterday's questions first. Okay. I hope I was not too fast. I just wanted I wanted to be on time, so I think I hurried up a little bit. Okay. So there was some question on some thermogenetic probiotics. Okay. Now, when I saw the question, I was wondering what it is. Then I immediately checked on my textbook, the standard gynecology textbook, and none of the gynecological, I'm talking about the standard textbook, none of them mention about this. Okay. Then, of course, I went on the internet. I got that information on Google. Okay, but it's actually probably that plant-based thing with some probiotics. And as I already mentioned, there is no scientific evidence. So none of our RCOG or ACOG recommends these probiotics. Okay, that's what I can say. None of our standard books have mentioned this. Okay, then the other question was about fibroids. I already mentioned that. Warning signs that, I mean, there's no screening for fibroids as such. When the patient comes to us with some symptoms, we investigate, or as I told you, they might have gone to a doctor for something else, and incidentally a scan is done, and then they come to us saying that they are having fibroids. But not all fibroids need to be treated. And one thing is, we have to reassure them that it is not cancer. 0.001% chance of it becoming cancer. Very, very small chance. So as long as it is not giving rise to symptoms, we can leave it alone. Unless, of course, patient is having other problems like she's keen to have a baby and other things like that, then only we may plan to operate. Regarding medical management of fibroid, not very successful. So many medical management came about, but they are all temporary. These medical management for fibroids are all temporary because once the tablets are stopped, they regrow again. Then about some cyst. I mean, I think it must be cysts of the ovary. That is what I think so. The question is, cysts of the ovary can be physiological, can be normal during the menstrual cycle. It can be normal. So, but when a lady hears that there are cysts in the ovary, they get worried. The main worry is they are worried whether it is cancer. That's the problem. So we have to tell them it is normal, but we have to follow them up. Most of these cysts will disappear by about 2 to 3 months. So we have to call them again and check on them. Or there may be cysts like endometriosis. Endometriosis also we call it as endometriotic cyst. If it is endometriotic cyst, we have to operate upon, medical treatment or surgical. Then one more thing, cyst means sometimes ovarian tumors may be cystic, but not all cysts of the ovary are tumors. I hope it's clear. Ovarian tumors may appear cystic, but not all cysts of the ovary are tumors.
What are the cysts basically? What?
See, I'll tell you, during the menstrual cycle, now the Graafian follicle is growing up, and when the Graafian follicle is filled with the fluid, and after some time it will rupture and the egg will come out. Sometimes what happens, that follicle doesn't rupture, the follicle keeps growing and the fluid gets filled up, and it is known as the follicular cyst. That's all. That's why I said it can be physiological. So also, after ovulation, there is corpus luteum which is formed. Again, the corpus luteum may collect and fluid can collect in the corpus luteum. That is called corpus luteal cyst. It's called luteal cyst of the ovary. That's why I said they are all physiological. We just have to reassure the patient. But of course, call them for a follow-up. After 3 months, you find out how it is. Sometimes these cysts can give rise to problem like the ovary can undergo torsion, it can undergo twist, and the patient can come with severe pain. Then we may have to think of operating if it is giving rise to problem. Otherwise, it's mainly reassurance and follow them up after 3 months, and it would have regressed on its own. And as I told you, endometriotic cysts, we'll have to manage them, or if it is a cancerous cyst, then of course it has to be operated. Tumor, or if it's an ovarian tumor or a cancer, then it needs treatment. Okay. The next question was on endometriosis. I already told that they severe pain, of course. It has to be treated. Endometriosis, we have medical management, we have surgical management, laparoscopy, and so on. Then what was that? Acne due to hormonal changes. Okay. Actually, acne is not, I should frankly say it is not a topic concerning me. We ourselves send them to the dermatologist. There are different types of acne and there are different methods of treatment. But one of the treatment what we offer is we can give them OC pills, which contains that cyproterone acetate, which will help in reducing the acne. I think, these days, we have to be very careful when we, we don't like to, go into another field, because litigation also has increased in India also. So what we are not well versed, we refer them to the specialist. Acne, there are various types of acne. There are 4 types of acne. It can be very severe. The dermatologists, they manage medical treatment, even some laser. I mean, there are so many other things. So I wouldn't like to go into that. Okay, what are the questions? One more thing, yeah. Okay, what steps can parents take to prevent it? Okay, PCOS, as I told you, you can't prevent it. Sometimes it can be genetic. We can't prevent it. Only thing is, I told you we should tackle it. Mainly weight reduction, lifestyle modification, controlled diet, and of course, sometimes we may need medication. But we have to be very careful. We should, before branding the person as PCOS, we have to be extremely careful, because the girl, the parent, they will be so worried about it. So we have to be very, very careful before we make a diagnosis of PCOS. We should not overdiagnose PCOS. Okay, these are the questions what were mentioned yesterday. Now,
so I think there is one more from yesterday. It talks about blood type compatibility and pregnancy, probably like a Rh negative and positive. Is that something?
That should not be a problem. I mean, if it is diagnosed, I mean, see, during the antenatal visit itself, we do the blood group of the lady. If she is found to be Rh negative, immediately we'll do the blood group of the partner or the husband. And if he is negative, then there is no problem. If both are negative, no problem. But if he is positive, then we take care. We do the indirect Coombs test on and off to see whether the baby is going to be affected. Usually the first baby is not affected. It's usually the second or the third, you know. It becomes worse with each pregnancy. So if we take precaution, there should be no problem. Only thing is, if they have had a miscarriage, if they had an abortion, and if she doesn't know she is Rh negative, she might not have taken the anti-D injection. That is important. After an abortion, after a delivery, she needs to take anti-D injection. That is
after the first baby, or is it?
Yes.
Okay.
After the, in fact, even during pregnancy at 28 weeks, we administer this. That's called prophylactic anti-D. At 28 weeks itself, we can give the anti-D.
Okay.
And even after birth. This is a very important thing. Because many a times they might have had an abortion at home, or they might not have known their blood group. And then when they come to us in the subsequent pregnancies, we'll find that she's Rh negative and she would not have had the anti-D in the after the abortion. Then that can be a problem.
Okay. So I will read questions from the chat. So there is one that asks, does having multiple periods in a month a classic sign of perimenopause after 40? Does this need evaluation, and how can periods be regulated again?
That is why I said after the age of 40, or definitely around after 45, if there is any irregularity in the cycle, it is better to be seen by the gynecologist. Better to have a proper examination, pap smear and ultrasound, if needed an endometrial biopsy. Then only the doctor will think of putting them on hormones, that is progestogens, for controlling the cycle. But without seeing the doctor, nobody should prescribe or swallow the progestogens. I mean, of course, the, phone consultations are not at all recommended. I mean, even in India nowadays, nobody advocates phone consultation. Otherwise, a lady may just call her, the doctor known to her, and she will tell, I'm having irregular period, give me some tablet. And the doctor may advise progesterone tablets. But as I told you, unless you examine, investigate, do the necessary investigations, we should never prescribe hormones. This can be corrected by giving progesterone. But as I told you, you have to examine, take a pap smear exam, see the cervix. He may be having a cancer of the cervix and he may be having that kind of a bleeding. We can't simply prescribe progesterone. So after a proper examination and evaluation, then we can give them progesterone tablets for that, that problem.
Okay. The next one is, can there be an increase in estrogen levels after menopause?
In fact, estrogen levels come down after menopause. It's the FSH levels which go up. I told you the ovary stops functioning, so the estrogen levels come down. Okay. If estrogen levels go up after menopause, then we really have to worry about it. It may be an estrogen producing ovarian tumor, you know. I mean, there are other things like that.
So it would be a cause for concern, or something that has to be evaluated.
Yes, definitely, because estrogen levels come down after menopause. See, when estrogen levels come down, you know, that negative feedback, the FSH becomes very high. That is one way of diagnosing menopause. FSH levels are very high in menopause. It means estrogen levels are very low. If estrogen is high, it is not normal. As I told you, these are all rare, but there may be an ovarian tumor which produces estrogen.
Okay. Is spotting common during menopause?
It is not common. Why should you have spotting? See, there are some conditions like senile vaginitis. I told you, with the lack of estrogen, the vaginal epithelium becomes thinned out. It is more prone for infection. She can come with spotting.
Okay.
But that's what I said. Anything postmenopausal, any kind of spotting or bleeding, we can't ignore. It is better to be examined.
The next one is there any concern for, just a moment, I lost that one. Is there any concern for starting breast cancer screening through mammogram starting at age 40 as opposed to age 50 in low risk patients?
That is what I told you, isn't it? See, there's always a tug of war between the UK people and the American people.
Right.
American people guidelines are different. UK guidelines are different. They are so confusing, you know. Even the American as I already told, American Cancer Society advocates from age of 40. Some other guidelines are they say start at 50. That is for the average risk woman. But as I told, high risk women, we should start at 30. There's no doubt about it.
So the next one, I think I will brief this thing. Somebody asked, are genetic tests for assessment of breast cancer covered in full by health insurance companies? That is something I think that is dependent on your health insurance company, and it has to come from a doctor. So it's a lot of them are not covered by insurance companies. So that's something you would probably have to pay from, your pocket.
And as I told, these are very rare. These genetic cancers are very rare. Out of all the breast cancers, if there are 100 women with breast cancer, only 5% are due to this genetic mutation. It doesn't mean we have to subject all these women for the genetic testing. The cost will be enormous. Right. So the doctor will decide depending on the risk of the woman.
Right. And I recently had a friend who was diagnosed with breast cancer. So after she was diagnosed, she actually got the genetic test done because her mother had died of breast cancer at a very early age. And that's when the insurance company did pay for that because she had she actually had the cancer. And she did get a mastectomy because, again, it's family history. And so she does have the genes. So
yeah, she should have started the screening earlier, by the age of 30 itself. In such cases, it is better.
Right. So the next one is, what is your opinion about Gardasil vaccination for adolescents in prevention of cervical cancer?
Yeah, that is recommended, but then again, it fell into disrepute in India because there were a few patients who had some allergic reaction. So when something goes wrong, some adverse effect event like that happens, it's a setback on the program actually. But it is said to be beneficial, but just because they have taken the HPV vaccine, it doesn't mean that they should not undergo pap smear. Pap smear screening is needed, even though they have undergone HPV vaccination.
Right. And is it recommended for, because I know here they're recommended for boys and girls. Gardasil is recommended for both boys and girls. So is that something, what is your opinion?
Yeah, it is recommended in that adolescent age group only. It has to be given actually.
Okay. Anybody else have any questions? One new message I see. Just a moment.
Aruna here, one more thing. Vidyaka, what you said, it surprised me, like lifespan of people has increased compared to 2 decades ago, like approximately 85. Out of that, 50 to 80, 85 goes through menopause.
Yes. Yeah.
And at 13 to, that's the age people usually, youngsters these days, yeah, this is not for me, just a casual question. I'm surprised that a younger generation who are not ready to go for marriage or having kids up until 30, 35, after 35 they would. So if someone gets married at 30 or decides to have child, only 15 years of their age from the time they married or up until menopause. So lot of time has gone. So what is your advice to younger generation about having children?
Very nice question. Actually, it is said that the ovarian reserve starts coming down. It's called ovarian reserve. The number of eggs starts coming down after 35. In some women, even after by the age of 30, 31 itself, the ovarian reserve starts coming down. So it is better women, do not postpone their childbearing for a longer age group. And of course, but these days there are many new things like oocyte retrieval. They may be married. They are more focused on their careers. And of course, it's the domain of the infertility specialists. I can't tell much, but what they do is they can retrieve the oocytes and they will freeze it.
Yeah.
Okay. And now then that lady, the person, they want to have a baby after they have reached the career has reached some stage at 35 or 40. Then they want to have a baby. Then the oocytes can be, used and they can have a baby. Those are all things which are being done. Oocyte retrieval. They freeze it and they can have a baby later. But apart from that, I think I would advise all women to have a baby at least before 30. And if they prolong, if they delay their childbearing, all these problems like endometriosis and all is more common in higher socioeconomic status as well as in women who delay their child.
Okay. One other question is, what are estrogen-rich foods to have after menopause? I know you did mention soy and tofu.
That's what I told, no? Soya nuggets, then tofu. That's what I mentioned that, I think, some red clover. These are all.
And then those would be. Do you have any more anything else to add to that?
No. I think I put that in the list that
right.
Red clover. I don't know what it is actually. I've never seen that also. But they're all plant-based.
Right. So anyone else? Any more questions?
Basically, all women, everything should be in moderation in life. Okay, it should not be too little. It should not be too much. So a healthy diet is important. Fruits, vegetables. Everything should be in moderation.
So I had a question. So you were talking about endometrial cancer. Is there a higher chance of somebody who has had a history of endometriosis to get endometrial cancer?
No. If there's endometriosis, there are chances of ovarian cancer. Okay. Endometriosis is actually, I told you, the endometrium is shed off.
Right.
It's not inside the uterine cavity, it is outside. And it will form cysts in the pelvis, on the ovary and all. There can develop endometrial cancer. Ovarian cancer.
Okay. Any other questions? So I have to say, Vidya ka bhari like jalna. It was a really informative talk and very helpful to all of us. I think itl namune ame prashne nimgile, and you were able to answer, all our questions and address most of the issues, and especially with regard to women's health. And most of us have come to that age where we are experiencing at least one or the other of these, or we have kids who are going through this. So we are really, really appreciative that you took your time. I know you're leaving in a few days, you must be busy, but you took the time to sit down and, address all this. So thank you very much for doing this.
I forgot to mention something. I mean, regarding this cancer cervix screening, of course, in US, I think there are, I mean, this is a health program itself. Women are called regularly. They are, maybe you are informed that you are due for a pap smear. Please come for a pap smear. I mean, it's all the screen. There are screening programs in India, in US or in UK. But in India, we don't have these screening programs. That is the biggest disadvantage. Otherwise, this pap smear screening really helps in reducing cancer of the cervix. So in India, what we do is, when women come to the hospital for some other reason, maybe some other complaint, we quietly take a pap smear. You understand? No? It's called opportunistic screening. We just take the opportunity and screen them. So that's the thing. And as I told you, every 3 years is best. Otherwise, at least once in your lifetime, at least once, one pap smear, or around the age of 40, at least once, or ideally at least every 10 years. This is the next best. If you can't stick on to every 3 years, at least once in a lifetime around the age of 40, or every 10 years, at least once, a lady should have a pap smear. I forgot to mention that, so I thought let me add it. And anyway, thank you for giving me the opportunity. I hope, I tried to clear your doubts. I don't know how much I was able to do that. Anyway, thanks once again.
Fantastic job. You did a really fantastic job. So
thank you.
And I must thank Aruna for initiating this whole series. So like in this session. So thank you, Aruna.
Thank you. Actually, Vidya, you came to layman level and gave us good information, which every woman should need. If it wouldn't have been this long weekend, there would have been more people probably. So, but still, whoever got to know this information will definitely, pass it on to. We use it for ourselves, for others. Thank you, Asima, for accepting my
phone number, WhatsApp.
No, and
one more thing I just want to add. Mom is also need to answer any other questions that cannot be answered here on WhatsApp. So please get in touch with Arunaka or me, and we can give you Mom's WhatsApp number, and she can answer any questions later.
Okay, will you put it in the chat box now for the?
Yes, I can do that.
Okay, perfect. And we are recording this. We have recorded this, so the recording is available to anybody who is interested in, watching it again or getting your questions answered. So this would be a good one, to pass on to friends as well.
Okay, thank you once again for giving me